Welcome to the Clinical Podcast Series brought to you by the American Academy of Optometry and the Clinical Binocular Vision and Pediatrics Care Channel. Today's topic, evaluation of pilot protocol for detecting infant hyperopia. Today's episode is hosted by April Jasper. The topical editor is Maureen Plaumann, and today's topical expert is Morrison. Now on with the show.
Hi, everyone. I'm April Jasper, and today I'm excited to welcome back Morrison to our podcast. Anne is an assistant professor at The Ohio State University College of Optometry, where she also received her OD in 2014 and PhD in 2021. Anne is a fellow of the American Academy of Optometry, and today she will be sharing with us some of her work from the May 2023 Optometry and Vision Science volume entitled Evaluation of a Pilot Protocol for Detecting Infant Hyperopia. Anne, welcome back.
Thanks for having me. I'm happy to be here.
So I have to know, what inspired you to conduct this study in infants? What was your goal?
So this is actually a smaller study that is a branch off of a much larger study that I've been working on for the last several years. So a lot of my research has been in early refractive error development in infants. And so one of the things I've been working on are ways to help infants who are at high risk for vision problems. So as we know as providers, most babies, if born with no significant health problems or health issues, most generally are born farsighted. And then during the first year or so of life, they generally lose that farsightedness to where they have a lower amount of farsightedness going in through early toddlerhood. But for whatever reason, there is a good portion, up to 10 to 12% of infants who don't undergo that emmetropization process. And what we're finding is those infants have much higher amounts of farsightedness early in development. So generally, we think about +5 diopters around 2 months of age is a significant risk factor for them not undergoing emmetropization, which is something that we want them to do. So my research focus right now is looking at ways to potentially help those high-risk infants undergo emmetropization so they aren't at risk for things like amblyopia, strabismus, and reading and early literacy problems. So that's the bigger picture of what I'm doing. But in order to do that research, I have to screen and find those highly farsighted infants. And so this publication was purely a report on the data that I found in seeking those highly farsighted infants, and is what I've published in this article here. Was
Wow.
What kind of stuff are we looking at these 2-month-old infants when I was screening them?
So that kind of helps us to understand where you found them, but why don't you tell us a little bit more about where did you find these kids and how did you evaluate hyperopia in them? And Anne, I'm a 5-diopter hyperope, so this is all really interesting to me as a patient and as an optometrist.
Absolutely. So I was fortunate enough to work with a great group of pediatricians in the Columbus, Ohio area. So I worked at Riverside Pediatric Associates.
Oh, wow.
They have 9 practicing pediatricians that I worked with, and they were gracious enough to allow me to come in and provide vision screenings for their patients. So as many of us know that either have children or work with children, the first year of life is crucial in developmental milestones for babies. And that's why they go to the pediatrician as often as they do. And so one of the visits that infants are generally asked to come to is a 2-month well visit. So I thought that was the perfect opportunity to try to screen infants prior to them entering emmetropization, which happens around 3 months of age. So what would happen is babies that were coming in for their 2-month well visit would get checked in. The medical assistants would bring them back and them worked up. And then I would come in and I'd give them a spiel about how I'm an optometrist and I'm looking to find infants who are at high risk for developing eye problems. And I'm providing free screenings to parents that were interested. And as you can imagine, most parents were excited at the opportunity. So they would sign a consent form, and then I would put 1% tropicamide in each of their eyes. And I would then let the pediatrician come in and do their full exam. So after about 20 minutes, when the pediatrician was done, a lot of times they'd have vaccinations completed. I would then go in and I would complete retinoscopy, and I would do autorefraction with the Welch-Allen autorefractor. So I had both an objective measure and compare it to my retinoscopy findings. If those babies were +5 or higher, I would then give them information about the clinical trial I was undergoing. Otherwise, I would just educate the parents on, hey, your kid's in this normal range, or maybe I found something like anisometropia or myopia and would refer them accordingly to where they needed to go. what I found really wonderful about this study was not only looking for these infants for my study, but it was a good public health initiative. I was able to talk to a lot of parents who had no idea that you could assess these things in infants. And so it was a good way to advocate for infancy and discuss the difference between a screening versus a comprehensive eye exam and talk to them about when they should have their children's eyes examined. So it was really a great relationship with the pediatrician's office. And I got to teach a lot of parents a lot of different things.
That's exciting. I love this. Well, tell me a little bit more about how that autorefraction compared to retinoscopy. And then was there a difference, and what kind of difference was there between tropicamide and cyclopenolate?
Yeah, so the big things to take away from the study are that the average refractive error for these 2-month-old infants was right over 2 diopters, which is what we'd expect. It was around 2.5. And one thing that we know, especially in the pediatric world with autorefractors detecting hyperopia, they don't really do a great job with high amounts of hyperopia. Their range is pretty limited. So as you might expect, my retinoscopy findings were a little bit more hyperopic than the SureSight findings, although not by much, only by about 1/4 diopter. And one thing that I discovered as I was going through the protocol, the range of the autorefractor, it only goes up to about +5, this one does. And so what would happen is, let's say there was a +6 baby that comes through, I'd oftentimes get an error reading because it was outside of the range of the autorefractor. So what I started to do, which my mentor, Dr. Muti, and other research has helped me, guided me, was I would take a +3 trial lens and I would hold it in front of the baby's eye and then take the autorefractor. And I would oftentimes work where I'd get this additive property. So it made the autorefractor work more for those highly farsighted infants. So that's a good tidbit for someone who's screening for hyperopic kids, is giving them plus might help you detect those highly farsighted kids. So they were pretty comparable. And then one thing that I did was compare. People often, I think in the pediatric world, there's this discussion like, oh, tropicamide's not as good as cyclopenolate detecting plus. And I'm generally pretty conservative. I think tropicamide does a pretty good job. And what I did was, the infants who qualified for the clinical trial, there were about 35 of them. They all got cycloplegic refractions as part of a study protocol, right? We got to give them 2 drops of cyclopenolate, make sure we wait 30 minutes. Not possible in a screening session in a busy medical practice. So I actually took that data of those babies who qualified and compared what was their cyclopenolate findings versus their tropicamide findings. And we actually found there was only about a 1/2 diopter difference. So the cyclo was about a 1/2 diopter more plus, which we might expect. A little bit better cycloplegic agent, but also they had 2 drops of it. They got to wait 30 minutes. So I actually think when you zoom out a little bit, this suggests that tropicamide is a very good tool to help screen for high plus.
It sounds exactly like that. And it's good to know, because that's what most of us have easily available in our practices.
Yep, absolutely.
So what key message would you like for our listeners to take away from this study?
Well, this study was more of an information divulged to everyone to show what we found in this population of about 450 infants in this Columbus, Ohio practice. Hey, we're seeing the plus. This is what we'd expect. So nothing out of the ordinary there. But I think it provides a good insight into how optometry and medicine can work together. As we all know, we are still on the fence about what we should be promoting. Should we be promoting screening? Should we be promoting full comprehensive eye exams? And the jury's still out, and the jury is definitely still out on what to do for these highly farsighted kids. So I think it's a really good insight into the fact that we can work with medicine, and there's ample opportunities to find ways for us to work with them to help find kids who are at high risk for vision problems.
And thank you so much for not only doing this today with me and helping everybody to understand the results of the study and how it applies, but just for being who you are and continuing to do studies like this. It's so important to all of us, and just a big thank you for that.
Oh, you're so welcome. Thank you so much for having me.